call it HDFN, HDN sometimes. We talked about this from day one, right? I talked about the problems, HDNS, and we'll get to it eventually. Well, we're there. We're finally to it. So when we start talking about hemolytic disease in the fetus and newborn, we're going to talk about what it is, symptoms, detection, monitoring, treatment, and lab workups. So what's going on? So what happens is something happens and fetal red cells enter maternal circulation, usually at birth. It can also happen like during an amnio or the CHV sampling, CV sampling, something like that. Anytime you're putting a needle in or there's anything like that, that's when we're looking at it. So the circulation, the fetal cells enter mom's circulation. Mom's immune system says, hold it, I don't recognize those cells. What are those cells? And the mother is going to be sensitized to them and produce antibody. The antibody, however, then can cross the placenta because it's an IgG antibody. It can cross the placenta and it's going to cause the hemolytic disease of the newborn. That's what's going to happen with this. Sometimes it may not happen with the first pregnancy. It may happen more with the second pregnancy. It depends on what stimulated the antibody production. So maternal IgG antibodies cross the placenta. The antibodies then coat antigen-positive cells, oftentimes inherited by the father. That's why the babies have it. The coated fetal cells become destroyed, and the cell destruction then in the baby is going to result in anemia and production of the bilirubin. So, what can cause this? Previous pregnancies. Most of the time when we're looking at fetal maternal bleeding, it occurs when the placenta is going to break away from the uterine wall at delivery. So that's a bloody mess, okay? Childbirth is not pretty. There it goes. So what happens, baby is born, placenta follows, it kind of breaks off and follows. If you remember, we sort of picture, do I have one coming up? Not really. Placenta, baby, it's kind of intertwined. I mean, placenta and the baby. Placenta is kind of part of mom, but the cells aren't supposed to cross. Small things can get across. So what happens, like the IgG can cross. The nutrients can cross. All those things go from mom to baby, which is great because that's how you get that passive immunity when babies are born. They have mom's immunity, all of mom's vaccines, antibodies, everything mom has, baby gets. And that's what protects them as littles until their immune system starts developing and their immune system can actually produce their own antibodies. All the nutrients, all that stuff that crosses over. Then going the other way, if babies, neonates, their livers aren't working well. So if you think about how a liver works to clear the bilirubin, and how, remember from your analysis we talked about how it gets excreted through the intestines. Babies' livers aren't working, so all those toxins go back to mom, and mom's liver clears them. So it's fascinating how this all works, and I can get into so much more detail, but we're not going to. But that's how it works. It's intertwined, and those small things can cross between the placenta and the baby.
So if the exposure occurs when the placenta breaks off, how does it then transfer through the placenta?
Because, well, the placenta is still part of baby, right? And when it's attached to mom, it overlaps. So what happens is it breaks off and it tears. And so you do have maternal fetal hemorrhage mix there when it comes off. So that's kind of what happens. It's traumatic. It's a traumatic tear.
Okay.
Does that make sense?
But it can still pass through the placenta that's on the baby.
Yeah. Well, what we're worried about is baby cells going through the cord to the placenta, breaking off, and now mom's body being exposed to them from in getting in where it met mom. Okay? So, previous pregnancy, that's where most of these come from. I've always been amazed with like the Dugars. She's had, what, 19 kids? How she could even have a kid? How is she not exposed to like 6 million antibodies? I don't know. Current pregnancy. Fetal cells often enter the circulation during pregnancy. Things like I said, we do an amnio. We take a needle in through mom's belly, into the uterus, into the cord. We find the cord. And then those cells, if that cord bleeds a little bit, it's in mom's uterus, it gets into mom's system, mom's going to recognize it. So that can happen. If you have a placenta abruption, I can't say that right, but where the placenta prematurely starts falling off, or if the placenta forms on the lower part of the cervix and kind of blocks the baby, it can kind of like tear off a little bit. So there's lots of things that can happen during that time that we can get exposed to those baby cells. Sometimes we can get IgG autoantibodies, panagglutinin, which means everything L-glutinate, right? And they can destroy fetal cells as well as maternal cells. So sometimes if mom has an autoimmune disorder and has a panagglutinin auto-IgG, we could potentially see problems then also. Previous blood transfusions. We try to make sure that when we give women of childbearing age, we're really super cautious about the D especially. We give the O negatives until we know what their D is. Because if we give a young man D positive blood, the chances of them going through another massive transfusion in their life is low. Most of us are going to make our entire lives without having a massive blood transfusion, thank goodness. But women are likely to have those babies, and we don't want them developing anti-D, especially against those future babies. If we do have somebody, a young childbearing age woman, they may get not only RH, but K. I think I mentioned it a couple lectures ago, how it's new that a lot of places are now matching K anytime they give a young woman blood, because K is super immunogenic and causes a lot of problems. So RH and K phenotype of matched blood, especially if they're going to need a lot of blood moving forward. So young cancer patients, even trauma patients, things like that, we're going to match as much as we can. Of course, first priority of a young patient, safe patient. But we do worry about those future babies. ABO antibodies, most common is IgG anti-A, B. So if you are an O especially, if you are type O, you can have an IgG anti-A, B. It's just one of those things that happens, especially in moms, super common in moms that have had babies, but it just happens. It's an IgG. You can also have IgG anti-A or anti-B in multiparous women, so women that have had lots of babies, lots of pregnancies. Wait, paras. P, pregnancies, babies. Is it G over P or P over G? I think, I can't remember if this is multi-pregnancies or multi-babies. Dang it, I think it's P over G, if I'm not mistaken. Okay.
It's probably multi-pregnancy.
I think it's multi-pregnancies, yeah. It's one or the other. So people who had multi-pregnancies can actually develop these anti-A and anti-Bs against those babies. IgG crosses the placenta.
The process of having 2 or more live births, not pregnancies.
Live births, thank you. But it must be G over P then. I can't remember what the G stands for. But anyway, thank you for checking that out. ABO is the most common form of HDN. Thankfully, it's the least severe. It happens a lot because there's 4 different blood types out there, right? It's like, oh, I can't marry you, you're not my blood type, sorry. Okay, we're not doing that. So, IgM maternal antibody, those naturally occurring, are not likely to cause the placenta because they're huge. So we're not going to worry about IH, Lewis, M and N, P. We're not going to worry about those guys because they're not going to cross the placenta. We don't have to worry. So, signs and symptoms of HDFN. First one is going to be anemia, because what happens in the body is the coated fetal cells become removed from circulation by their spleen. So a normal newborn hemoglobin is 14 to 18, which is pretty high, but that's kind of the normal. HDFN hemoglobin drops below 10. That becomes super problematic. Fetal bone marrow compensates by producing more cells faster. What type of cells do we call those, especially in adults? Reticulocytes. Okay. Younger red cells start entering the circulation. And then, because of that, you're going to have different sizes of cells. They're going to be in there. It's going to be depleting the bone marrow, trying to keep up. But what's going to happen in circulation, those cells are going to continually be removed by the spleen of the baby. So then what we're going to have is we're going to have an increased bilirubin caused by an increased red cell destruction. In utero, the released amniotic fluid, they get released into the amniotic fluid, and the mom is going to conjugate and excrete them. So mom takes care of that. That's what I was talking about. Their livers aren't developed as babies, but mom's liver takes care of them. The problem is, at birth, if they have this a lot, their bodies aren't going to take care of it. So what's going to happen is the liver can't process it, and it's going to accumulate then in the baby. It's going to cause baby jaundice and kernicterus, which is bilirubin in the brain cells, which is going to cause plaques in the brain cells and can cause long-term brain they call it retarded brain development, lack of brain development where it's slower and stops growing. So if it gets really severe, we get into this HYDROPS. And what HYDROPS is, it's a severe anemia, causes the heart to work harder, trying to get the oxygen, because we're not getting enough oxygen throughout the body, leads to heart failure. Heart failure is going to lead to edema, and then hydrops fetalis is generalized edema, and you can end up with intrauterine death. So here is an infant with severe fetal hydrops. So this is bad, okay? So prenatal testing, what do? First visit, I talked about this from day one. First visit, they're going to do an ABO-RH and an antibody screen. Fingers crossed, it all looks good, your screen is negative, and we're not going to have to worry about it during the rest of the pregnancy. If your antibody screen is positive, they have to identify it if it's an IgG. Because we need to know what's going on. What antibody is that? Because that IgG can cross the placenta. So, if we find an IgG, one of the first things we're going to do is get father, and we're going to type the father for that antigen. What problems might we have here?
He's not the father.
He's not the father, right? People are really hesitant to say what's going on. A lot of people, when you go through like fertility treatments, that stuff doesn't go on your record. Because those are private clinics. So unless you transfer them over and you tell your doctor, they may not understand that you had, an egg donor. It may not even be the father. The father might be the father, but if that's an egg donor, the baby still could have that antigen. How does that baby have that antigen in the egg if, it's egg donor? So you really have to be aware and talk to the patient about the importance, not you, but the physicians, about the importance of, you have this antibody, do we know for sure this is the father, and by father, the sperm donor. Remember I talked about that when we talked, it's like egg and sperm. I don't care who you call the father. I don't care who you call the mother. But when we're talking about mom and dad, whenever I talk mom and dad, I'm actually talking sperm and egg, okay? So, for example, mom has anti-big K. If dad, sperm, is K negative, 0% chance for the baby to have K, for the fetus to have K. Best case scenario. Dad is big K positive, we're going to type for little k. Most people are going to be big K, little k, right? Because 99.9% of people have little k. 50% chance. Dad is homozygous big K, 100% chance. Because no matter what, they're going to get one big K, so they're going to have that antigen. If D, we cannot type dad for little d. If D positive, right? It's a placeholder. It's a probability. It's those number games that we talked about before. We base it all on probability. So we're going to do Rh phenotyping or molecular analysis to determine is dad, for example, big D, little c, big E, big D, little c, big E, versus big D, little c, big E, little d, little c, little e. So we have to do the typing and do the numbers to try to figure that out. If it's an antibody that can cause HDFN, we're going to titer mom. Did you guys do a titer in DIC? Did you titer anti-D?
We didn't do it with anti-D. We didn't do an actual test, but we did like theoretical stuff.
Okay. We used to have you actually run one, so I was wondering if you did it. So we do serial twofold dilutions.
Oh, we did do that. Just not with anti-D.
Now anti-D was something else? Okay. We used to have you do it with D because it was part of the workup for the baby, because the baby was the mom. I can't remember if it was like early in their life or late in their life where we did they became a mother or something. But anyway, so it's important to test these in HG. We don't use gel, we don't use PEG, we don't use any of those things. We need to know what's going on. The titer, we know it's reciprocal. of the number giving the highest 1+ reaction. What we're going to do is we're going to do that titer, but then we're going to save that sample in the freezer. At some point in a later visit, we're going to get a second sample, and we are going to test that second sample, and we'll test that first sample again with it. Why do we have to retest that first sample? Do we all shake exactly the same? No. What Jillian might find is a 1+, Alex might find is a 2+. So Alex might get one tube farther out, which would be clinically significant, versus if he did it side by side, they'd be run the same. So it's really important to make sure that when you run these, you run them in parallel with the same procedure and the same person, so that everybody's shaking is exactly the same. Remember I told you from day one, like you might, is this a 2 or a 3+? As long as you are consistent with how you're reading it, that's what matters. That's what's going to matter in this situation too. The titers in general are subject to a lot of human error because they're very manual, so it's really important that you run them side by side. So, subsequent prenatal visits, we're going to repeat the titer, compare to previous sample, test them in parallel. Significance increase in titer is 2 tubes, which is a 4 times increase. So in this situation, the first prenatal sample is a 1+, so it's an 8. The titer is an 8. And previous ones, it's the last 1+. You wanted at least 1+. The week doesn't count. That's a 64. That's 2, 4, 8. That's an 8-fold increase. So that is significant. Now, not only is the increase significant, but there are critical titers for certain antibodies. For example, anti-D, the critical titer would be 16. If it's a 16, it doesn't matter if it's going up or not. That's critical. We need to start watching that baby. K, it's only an 8. So it's really important. If we do these titers initially, and that's where they come up, it's really important we start watching that baby a lot more carefully. We end up starting doing more invasive techniques at that point to monitor the fetus to see what's going on. So we're going to do amnios. So by ultrasound, they determine the fetal position. They insert the needle into the uterine cavity, and they withdraw amniotic fluid. Now, this is not a willy-nilly test. We're not going to do this willy-nilly. There's a lot of things that can go wrong. So they're very, very cautious during this test. They're going to withdraw the amniotic fluid, and they're going to test the amniotic fluid for bilirubin. How much bilirubin is the baby producing? If they're producing a lot of bilirubin, we need to start worrying. We're going to look at the LS ratio. I can't say it. The LS ratio is the lung development. When the LS ratio gets to a certain point, we can deliver that baby safely. Sometimes we have to deliver that baby earlier, but their lungs aren't mature enough to go on their own. And those babies will end up in the NICU a while. That's why babies end up in the NICU. Most of the time it's lung function that's causing the problem. We're going to do chromosome karyotyping to determine any abnormalities, genetic abnormalities possibly at that time, because we're already doing the amnio. They actually offer amnios to anybody that's 35 or older, because if you're 35 or older, they consider you a geriatric mother. So some of you guys aren't that far out, you're almost geriatric. So a lot of times for these geriatric mothers, they'll offer it early on just as a way to, like, in case you know, so you know. It's up to people to determine what they want to do, but as I said, amnios are not safe, and you are sitting there and you're not allowed to move. You aren't allowed to breathe deep. You know, if you get a muscle spasm, you know, whatever you do, you have to lay there because there's a needle in there right next to your baby. So there have been stories about amnios, you know, babies losing fingers and toes because of the amnios, because they're so tiny at this point, and it's really easy to mess with it. So do not measure this, do not memorize this graph, but what this graph is the amount of bilirubin and the amniotic fluid plotted on the graph versus gestational age of the fetus. So this is the age of the fetus, this is the amount of bilirubin. The 3 zones, this is low risk. Now you can see, the older baby gets, the low risk goes, less and less and less bilirubin. Zone 2 is moderate risk, monitor the baby closely, and zone 3, intervention is needed. If you start, notice how it stays high the whole time. If you're at that point, we need to immediately do intervention. And what the intervention will consist of is a percutaneous umbilical blood sampling, which is a PUBS. They actually stick the needle, use an ultrasound, stick the needle into the base of the cord, and they actually are going to sample fetal blood at this point. It's also called a chordocentesis. What happens is first thing we're going to do is test for hemoglobin F to make sure we're looking at a fetal sample. Because it does us no good to test the mama sample, right? So we want to make sure we really found the cord. So they put the needle in there, and the needle's going to sit there, gang. It's going to sit there during this whole process. And you can't move, hangs out there. They want to make sure it's hemoglobin F. Once they know it's hemoglobin F, they're going to do a hemoglobin and hematocrit, a DAT, an ABRH, and an antigen type against whatever the antibody is that mama has. Because obviously something's causing the problem, and that's what we assume, but we have to verify it, right? Just like we antigen type the patient at the end to verify they don't have the antibody we're looking for, or the antigen we're looking for, that's what we're looking for there. So if the hematocrit is too low, if the bilirubin is too high, or there are any signs of HYDROPS in the baby, we have to intervene to save the fetus at that point. If this is the lecithin, whatever that says, the LS ratio, if that LS ratio is 2 to 1, the lungs are mature enough, let's deliver this baby. Okay? If it's too early to deliver, then we're going to start performing what's called an intrauterine transfusion. Okay? The intrauterine transfusion, they stick this little needle in, like I said, and they're going to, the blood they're going to give, see how little bit of a blood that is? Remember how little these babies are. It's not going to be a whole big unit. Group O, antigen negative for mom's antibody. Wherever mom's antibody is, it's going to be antigen negative. It has to be fresh, less than 3 days old. We want it like super, super fresh. We wash it because we don't want to give any plasma. We're going to wash it. Super pack it to a super high hematocrit because we don't want to give extra fluid to this little baby because we're going to end up with problems. Leukopore, run it through a filter. We don't want to give it white cells. Irradiated, CMV negative, hemoglobin S negative, that's sickle. We want to make sure we're giving it healthy cells. And we want to cross-match it with the mom's sample to make sure it's not going to react with mom's plasma. So, at delivery, mother's sample, we're going to do an ABR and RH again. We are not testing mom for weak D. If mom's D looks negative, we're treating her as negative. If she looks negative and we do a weak D, and now we've found that she is weak D positive, now what? Do we treat it? Do we not treat it? Do we give her program? How do we move forward? It complicates everything. We do not test moms for weak D. We're going to antibody screen mom again, and if it's positive, identify it. Newborn sample, we're going to get cord blood. When you get cord blood, you have to wash it at least 4 times because it's covered with mucus. We call it Wharton's jelly, and it's super mucusy and globby and icky. So you have to wash it at least 4 times to get all of that off. Then, on the baby, we're going to do an ABO, forward grouping only. We don't have any plasma or serum on the baby. We just have this cord blood. So forward typing only. We're going to RH. If baby is RH negative, we're going to run the weak D. So we don't do it on mom, but we do it on baby. Because if baby is weak D positive and mom is D negative, she could still be producing antibodies to whatever's causing that weak D positive. We're going to do the DAT, but we're only going to test for IgG. And then if the DAT is positive, then we're going to do an elution. So what is an elution? Everybody remember, what does it mean? What's an elution mean?
Wash off antibody from DAT positive blood samples, and then you test to see what they are.
We're not going to wash it off. We're going to what?
Use acid in a DAT, but in this case it's Louis-Freeze.
Yep, in this case it's Louis-Freeze. So we're going to break that bond. Because when we wash a cell, all we're washing away is anything loose. So we're going to wash it real good, get all that loose stuff out of there. But now we need to break that bond where you have the antibody on the red cell. Because we want to know what the antibodies are. So that becomes our Louis-Freeze. So this week we're going to talk about the acid elution, where we use the acid to break the bond. This week is called Louis-Freeze. It's really good for harvesting antibody, especially ABO from cord samples. Newborn cells get washed several times to remove all that plasma antibody, Wharton's jelly, all that stuff. The cells then are frozen briefly, and then they're thawed rapidly. And by doing that, what happens is it destroys the red cells and all the antibody gets eluted off, and now it's present in the supernatant. And now we're going to test it against A cells, B cells, and screening cells to see what's going on. And then possibly, if the screening cells are what's positive, we're going to test it against the panel to figure out what's causing the problem. We kind of should have an idea based on what mom has, and so we can do just a partial panel at that point, but we need to rule out everything else. So, as I said earlier in this lecture, ABO HDFN, that's going to be our most common HDFN. Can't really prevent it unless we specifically pick who we're going to marry based on blood type. It's relatively mild. Maternal ABO titer is not going to be really high because it has to be an IgG ABO titer, so that's not going to be real high. ABO antigens are not very well developed on a fetus. Remember we talked about it? They don't really develop fully until about 6 months. So because of those, it's going to be pretty mild. We're going to do mom typing. Usually it's an O mom. Not always, but usually it's an O mom. Antibody screen is negative. The baby is either A or B, and the baby DAT is weakly positive, and we end up recovering anti-A, B most of the time in the eluate. Okay. Now, RH HDFN. This is what is the most severe. Thankfully, it's not very common anymore, but it is the most severe. Remember back when we talked about RH? Early on, we talked about it being developed. We figured it out in like the 30s, but it was like 1968 before we developed ROGAM. So if you go back and like look in old family cemeteries, you can see like lots of kids, like a farm family, for example, where a lot of kids would die like year. And it was things like this. So it was one of the many things. It was plague. It was, we didn't have a very good infectious disease system back then, but many times it was this. As I said, usually it's very severe. RH antigens are pretty well developed on infants because remember they go in and out of that cell membrane, and so they're like an integral part of that red cell versus ABO where they're just hanging out on the outside. Especially if the baby has big R2, little r, because it has a stronger D expression because there's no big C right next to it to inhibit that expression. So D is super expressed. Maternal antibody made up in the thousands. Pre-1960s, as I said, super common cause of intrauterine death. Now we can prevent it with RH immunoglobulin prophylaxis. So RH HDFN, mom is RH negative. We don't do weak D. We just use regular D, and she's RH negative. Antibody screen is positive due to anti-D, often a very high titer. You're going to have really big positive numbers there. Baby is RH positive. The DAT will be very strong. And then when we do the eluate, we'll find anti-D. Other kinds of HDFN we're going to see, any maternal IgG antibody where the antigen can develop in the fetus can cause HDFN. Big C, little c, big E, little e, Kel, those are going to be our most common after D. Duffy, Kid, SNS can all cause problems. Thing is, Duffy, Kid, and SNS usually require more than one exposure to develop the antibodies. So it's not going to be really common that mom's going to have a significant exposure from baby. It would have to have been from multiple transfusions or something at a later point, or 19 kids, 19 exposures or whatever. Aren't they at 19, that Duger family? I don't know. Anyway, they have a bunch. They have a boatload. As I said, anti-Kel is particularly dangerous. They not only, this is kind of it's one of those interesting like side facts, they not only destroy fetal cells, but they actually suppress production of new fetal cells. This is why when we know we're going to give a woman of childbearing age a bunch of blood, we a lot of times are typing for Kel now to make sure we don't give them Kel blood. Other kinds of HDFN, mom maybe ABRH type, it could be any ABRH type. Antibody screen is positive to IgG antibodies other than D. Baby has inherited the antigen from the dad. Baby's DAT is positive. Eluate shows the same antibody as mom's plasma. So it works the same as any of the others. So treatment at delivery, what do we do about this? So we want to treat that elevated bilirubin because we want to prevent that kernicterus. That kernicterus is going to cause brain plaques, and as I said, it's going to cause slow mental brain development. We don't want that. So what happens with kernicterus is bilirubin enters the fatty tissues of the brain and causes neurological damage or death. So phototherapy is going to be one of our most common. That's especially if it's a low amount of bilirubin. Most babies are born slightly jaundiced. Actually, I shouldn't say that. They're slightly jaundiced about 24 hours after they're born. Because while they're still in mom's taking care of their bilirubin. As soon as they're out, their livers are kind of like, whoa, they got to wake up. They got to start functioning, right? So 24 hours after babies are born, a little bit of jaundice is super normal because their livers are just kind of starting to catch up. But it's when they start getting more severe that we really worry about them. Most of the time, if you have a baby in the summer, they'll say, take the baby to the park. You put them in a diaper and put them in the backyard. Things like, not alone. I'm not saying like a dog or anything, okay? But that really used to be like the best way to treat it. Well, in Wisconsin, that leaves us, what, 2 months a year? Where we can actually be out in the backyard in just a diaper. So we have these photo-billy lights. This is fluorescent light, and they cover their eyes and protect their eyes. And that's very common for babies with mild jaundice. We can also do transfusions and exchange transfusions. So this is an exchange transfusion. That baby looks way more than newborn, just so you know. So what they do is they insert a catheter into the little bit of belly button that hangs out. So when the baby's belly buttons are there, you know, they cut them, but they kind of like hang out a little bit for a while until they get absorbed back in. And they put a needle in and they attach a little two-way valve. When you guys were in chemistry, did anybody here use like a big biuret? They would do the drop, 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 and calculate the amount of acid to turn something, you know, to miss a buffer. So that's kind of what this is. They're going to titer it down in. So what they do is they withdraw 1 millimeter of baby's blood, and they're going to replace it with 1 millimeter of fresh normal blood. They're going to continue this until 100 to 200 millimeters has been exchanged. That's a lot, right? Pull a little, give a little. Pull 1 ml, give 1 ml. Pull 1 ml, give 1 ml. So it's going to take time. It's very, very time consuming. But we're trying to pull out all that extra waste product when we're doing this. We're trying to get all those toxins out, all that bilirubin out, those broken cells, all the cells that have the antigen. Because remember, we have that passive antibody for mom still in us. Passive antibody for mom is great for disease prevention. But it's not great when we're hanging out with anti-cal from mom and we have cal in our bodies. So we're going to exchange that blood 1 ml at a time. Blood for exchange transfusion is very similar to the blood from intrauterine. Should not be quite so super packed. We're going to adjust the hematocrit to 50 to 60%, which is more than normal hematocrit of a newborn. We're going to use fresh AB plasma to adjust. Why AB plasma? No antibodies. Yep. So we're going to use fresh AB plasma to adjust. We're going to use mom's sample again to cross-match because baby has mom's passive antibodies in their system. So we want to make sure that we're not giving the baby something that mom's antibodies are still going to continue to destroy. So benefits of exchange transfusion, like I said, it's going to remove the bilirubin. It's going to remove the free antibody, anything hanging out still that's not attached. We're going to get rid of it. Remove all the antibody-coated cells. It's going to replace it with fresh, normal antigen-negative cells. Can also be used for other conditions unrelated to HDFN, which include things like sepsis if the baby's born septic, if they're disseminated intravascular coagulation, or respiratory distress due to an elevated fetal hemoglobin. So we can do exchange transfusions for other things. So you might get an order for an exchange transfusion in the lab. Anytime you're dealing with a newborn, just think through. It's always the same with how we're working it. So summary, ABO HDFN is going to be our most common but least severe. RH HDFN is going to be our most severe. Thankfully not very common anymore. In utero anemia and HYDROPS are of our greatest concerns. That's what we're going to worry most about. At delivery, anemia and bilirubin are our greatest concerns. We're going to detect the potential for HDFN with prenatal testing on mom with that ABORH screen. If mom has a clinically significant antibody, we're going to monitor with titers initially, and we're going to try to find dad. Get dad, sperm, mom, egg. We're going to do an amniocentesis to monitor the bilirubin levels if mom's antibody titer gets high. We're going to do an intrauterine transfusion if the anemia is too severe and we can't deliver the baby yet. We need fresh, super packed blood with all that special criteria for intrauterine transfusions. At delivery, we can do the HDFN workup. If the baby's DAT is positive, we can elute off and identify the antibody. Should be the same antibody mom has. We can transfuse the baby if needed or perform an exchange transfusion if HDFN is severe. Exchange transfusions are better for babies than a regular transfusion because otherwise, think how little they are, how much blood can they really get that's going to make a difference in their tiny little bodies without causing cardiac overload.